All right, we are live. Hi, everyone. My name is Tim McMahon. I'm Director of Marketing here at St. Joseph Hospital. And tonight I am joined by some very special guests as we'll be talking about the importance of colon cancer screening and awareness. Now, tonight we have three people with us who will be kind of running the show. I'm really just here for backup. And we have two of our fantastic providers, Dr. Gulur and Dr. Lim, who will be answering both some of the common questions we often get here at St. Joe's about colon cancer, but they'll also be answering your questions. So throughout the broadcast, if you have a question, feel free to type it into the chat box below, and we'll see it right away, and we'll make sure these fantastic providers answer it for you. Now, we're also joined by Amy Devitt. Amy Devitt comes to us from the American Cancer Society, and she'll be moderating this entire process and asking the questions of these providers. So, Amy, with that in mind, I'm going to hand it over to you.
Excellent. Thank you, Tim. What a pleasure to be here with this panel of experts this evening. We have already received some great questions from our listeners. We will get started with those in just a moment. During tonight's presentation, it's our hope to dispel the myths, minimize your concerns about screening, and ultimately inspire you to get screened. It's our intention to answer: what is colorectal cancer screening? Why should I get screened? Who should get screened? And actually, how is screening done? This is a time for you to join in and ask those pesky questions you may have on your mind. We want your questions. So as Tim said, please add them to the chat anytime throughout this evening's presentation, and we'll answer as many as we can. And with that, let's get started with our first question to you, Dr. Gulur. What is colorectal cancer screening?
Colorectal cancer screening is basically any test used to try and find colon cancer before it has produced any symptoms, to look for those people with absolutely no symptoms, to try and find the precursors for colon cancer, or in some cases colon cancer itself.
Excellent. Thank you. And Dr. Lim, what age should I begin colorectal cancer screening?
So the guideline has changed actually as recent as this year. In the past, it used to be, we would advise patients to start screening at age 50. But as of this year, or actually last year, the guidelines have changed in a way that everybody should begin colon cancer screening at age 45. And people who have an increased risk of getting colon cancer sometimes even begin screening at a younger age. And those are people with family history of colon cancer, and people with inflammatory bowel disease, or which are autoimmune problems, either ulcerative colitis or Crohn's disease. And in general, it depends on what we see during a colonoscopy, and that will decide when the next colonoscopy will be.
Can you elaborate a little bit, like what time in between, depending upon maybe say a different, they have a inflammatory, is there a recommended time in between screenings?
Yeah, so it depends on what kind of polyps we see. So polyps are little like outgrowth in the colon that is a result of changes in your mucosa over time. And so depending on the type of polyp we see, that would determine when the next colonoscopy will be. So there are, in terms of the polyps itself, there are what we call benign polyps or non-precancerous polyps, and there are precancerous polyps, things like, tubular adenoma or sessile serrated polyp. Those are terms that were coined in the past to indicate precancerous polyps. And so depending on the number, the size, the histology of the polyps, that will determine when the next colonoscopy will be. In general, if we see no polyps, the screening guidelines recommend 10 years. If you see small non-cancerous polyps, such as hyperplastic polyps, the screening guideline again recommends 10-year interval. But if we see bigger polyps or polyps that could be precancerous, such as tubular adenoma, big words for precancerous polyps, then depending on the number and the degree of changes in the mucosa in the polyp, that would determine when the next colonoscopy will be. So it could be either 7 years, 5 years, 3 years, or even a year after the first initial colonoscopy. So it really depends on what we see when we do the colonoscopy and how big it is, and whether or not you have a family history of colon cancer.
Okay, so it really sounds like a case by case.
Exactly.
Yeah, there's some, as she pointed out, some other nuances like family history, having inflammatory bowel disease, having a polyposis syndrome, how good a look you got at the time of your colonoscopy. All of these
Yeah.
are included in the guidelines that help us determine, as you say, tailor-made to the individual guideline.
Yeah. So just to jump in on that. So in general, in patients, in a regular healthy patient with no family history, the guideline states that at age 45, that's when you get some sort of colorectal cancer screening, and we'll kind of go into the different types of colorectal cancer screening techniques you can do. But if you have a family history of colon cancer, say your dad or mom, someone in your family has colon cancer, we usually recommend getting a colon cancer screening either 8 years before the diagnosis of that colon cancer in that patient or in that family member, or at age 40, so whichever is earliest. And if your dad or mom, whoever, was diagnosed with colon cancer before the age of 60, we tend to recommend a repeat colonoscopy every 5 years. And if it's not, if they were diagnosed at age 65 or 70, for example, then it depends on what we see, and that would sort of revert back to the guidelines that we follow to determine when the next colonoscopy will be. Yeah.
Now, Dr. Lim, just and Dr. Gulur as well, we actually have our first couple of questions already streaming in on Facebook. So hopefully I'm not interrupting, but just want to throw these out there so we don't forget them. You mentioned precancerous, and one of our viewers asked, "What does precancerous mean?"
So, you want to take it?
No,
So precancerous polyps are polyps that could potentially transform to become cancerous. These are polyps that, on pathology have like histologic findings are concerning for a precancerous polyp. So things like tubular adenoma, I don't know, if you've had a colonoscopy before, your gastroenterologist may, tell you about this precancerous polyps such as tubular adenoma or sessile serrated polyps. Those are just very fancy terms, very technical terms to describe a precancerous polyp. And so there are polyps that could become cancerous if it's left untreated, if it's left in the colon for a long period of time, years and years, without removing it.
Great, thanks. And a second question that just came up was, should you be screened for colon cancers if you have a lot of issues with hemorrhoids? I have some friends who suffer from hemorrhoids. Is this something of concerns in terms of rectal type cancers that should require screening at younger ages?
So it's a good question, but in themselves, hemorrhoids don't predispose you to colon cancer. But one of the most common causes of rectal bleeding, are hemorrhoids. In fact, the most common. However, many people with recurrent rectal bleeding who believe they are bleeding from their hemorrhoids can in fact have colon cancer. So guidelines are here and in Europe and the UK, anyone with recurrent rectal bleeding, even at very young ages, should have an evaluation, preferably a sigmoidoscopy or a colonoscopy, which are just basically procedures to take a look in to make sure that it is indeed the hemorrhoids that are bleeding and not something more sinister. So it's a very good question. It brings up a very good chance for us to put that in there, that while screening is looking for colon cancer without any symptoms, recurrent rectal bleeding, which people may believe are from their hemorrhoids, could be one of the earliest symptoms of having a colon cancer, even a bleeding polyp.
Okay.
Great, thank you. So Amy, back to you. Just I wanted to throw those questions in.
Oh, those are important. That's some really great information. This question goes back to you, Dr. Gulur. So are there options for screening for colon cancer, or is colonoscopy my only option?
No, there are, in fact, numerous options, starting from stool tests of different types, endoscopic procedures of different types, and radiological procedures of different types. One of the most common tests used are stool-based testing for microscopic amounts of blood, and these days for DNA. And among the radiological procedures, the old-fashioned versions were the barium enemas, where the radiologist would instill a liquid into the colon that could be seen on X-rays, have the patient change position, and then look for polyps or cancer. But nowadays they have far more advanced techniques, CT scan based. The donut-shaped X-rays everyone's so familiar with, where they can be very effective in finding polyps of a certain size and colon cancer. Among the endoscopic procedures, you have a limited form of endoscopy called a flexible sigmoidoscopy, which involves examining about 10 inches of the colon, and it can be done without sedation and with a much smaller prep. But it has the limitation that it covers such a small portion of the exam of the colon that it can miss what we call proximal lesions almost 50% of the time. And then, of course, we consider the gold standard as a colonoscopy, which is a complete examination of the colon. I hope that gives you a brief overview.
There's a lot of options. So, Dr. Lin, how do I know which test to have? How do I know what's right for me?
Yeah, so in general, we always recommend like a full colonoscopy screening, just because it's not only a diagnostic procedure where you go in and look for polyp. It's also a therapeutic procedure in which you can take out the polyp in the same setting. The fecal test, the FIT test, and the fecal DNA test are good for patients who cannot tolerate, for example, cannot tolerate a preparation or have certain cardiac or other types of comorbidity that would put them at a high risk for colonoscopy. Because in a colonoscopy, you would get sedation, and with sedation, there's always a risk for respiratory depression and some other side effects from the sedation. The only caveat for stool-based testing is it's proven actually in a lot of studies that it's not as sensitive as colonoscopy. The fecal DNA carries a little higher sensitivity than the FIT test or the fecal immunochemistry test, but it's still not it's not as great as a colonoscopy in terms of the sensitivity. And even then, it's also only a diagnostic test, which means if it's positive, if it comes out positive, you will have to do a colonoscopy anyway to complete the screening process. So in general, I think a discussion between your primary care provider or the gastroenterologist should be done to kind of discuss the risk versus benefit of each and every test. And ultimately, there's no one wrong test or no one correct test. It's just as long as we encourage everyone to get at least some sort of colorectal cancer screening, to prevent colon cancer, because colon cancer is it's so prevalent these days. It's actually the second leading cause of death after lung cancer in America. So I think a discussion with your primary care provider or gastroenterologist should be made to decide what the best testing should be for you.
Yeah, it's definitely what she said. It's a shared decision making. Everyone has values. Everyone has fears, and it's very important they address those concerns with a medical professional who has the information they need to help them make the best decision for themselves. And they make any choice is better than no choice. And that's what is emphasized by all screening societies. Do something. It's much better than doing nothing.
Right.
Yeah.
That test is the test that gets done.
Correct.
Right.
That is correct. Yeah.
Okay. So we have heard some of the pros and cons to the screening options that we've talked about. Is there anything else you'd like to add about the options that Dr. Lin shared with us, Dr. Gulur?
So, as she mentioned, these words, you'll hear a lot about sensitivity and specificity. What sensitivity means is how likely a test is to pick up a cancer that you have, and specificity is how likely is that test correct. So it's important in stool-based testing because they can be very sensitive, sometimes super sensitive, but also they have the limitation of being non-specific. So just because they are positive does not mean you have colon polyps or colon cancer. Stool-based DNA testing, unfortunately, has up to a 40% false positive rate. So that's important to understand. Colonoscopies do not have a false positive rate. So it's not likely that you would be diagnosed, or you would be concerned about having colon cancer with misdiagnosed at a colonoscopy. And so that's one of the limitations of stool-based testing. The biggest advantage for them is their convenience. They can be done at home, no sedation involved. But a positive test will result in a colonoscopy or a similar test.
Tim,
So,
did you have
Amy,
it?
I'm sorry, I was going to jump in, and it's just, again, I am the marketing director, so I'd be remiss if I didn't mention that, by the way, we are talking about colonoscopies and screenings and scheduling appointments. So if you would like to schedule an appointment at St. Joe's, again, with one of our amazing gastroenterologists, you can please call this number, 603-578-9363. It's at the bottom here of the screen. So, call us, make your appointment, and we'll share this this phone number again throughout the broadcast. But we're trying to encourage people, especially who are 45 and over, to get screened, and we want you to call us. We want you to come in and make those appointments. So sorry, had to do it.
Perfect segue, Tim, into my next question. We're encouraging you to reach out to get scheduled. But if you still, after tonight's presentation, have some questions, where should we start, Dr. Lim? Who should we contact? What should we do?
I think the most important thing is echoing what Dr. Gulur and I have said earlier, is to really have just to start the conversation with your primary care provider. They have all the resources, all the numbers that is available that will be able to help you with a decision. Say if you're after this discussion, if you're still very hesitant about getting a colonoscopy with the preparation and you're afraid of the sedation risk, there's so many different ways to screen for colorectal cancer. There's the fecal-based test and the imaging test, and so the most important thing is just to do something about it. It's better than nothing. So the first step is to always call your primary care provider and talk to them, initiate the discussion if you're age 45 and above, or if you have a family history of colon cancer, and you want to talk about it, to kind of discuss the options for colorectal cancer screening at an earlier age. So that's the most important thing, is to initiate the discussion.
And while this particular live discussion is about screening, to also emphasize that any symptoms that you may
yes, correct.
Be having and have been hesitant to discuss is very important to bring up with your primary care provider. Something as much as a bowel change, bowel habit change, or unexplained abdominal pain, or rectal bleeding, or painful hemorrhoids. It can start a very important conversation.
But Dr. Gulur, what if I'm not 45? What if I'm 30 and I'm having some weird symptoms?
Absolutely. The youngest, and this is not to say that everybody, should get alarmed, but the youngest person that I personally diagnosed with colon cancer was 18 years old. It is increasing in the population that is under the age of 40. Still a very low absolute risk, but the proportion of patients being diagnosed with colon cancer under the age of 40 is rising. And that is why the guidelines have been revised, to try and find more patients before they have symptoms. So at any age, if you're having concerning symptoms of any kind, it's as simple as just meeting with your primary care and discussing them, and letting them decide what is the best next step.
Thank you. Great.
Hey, by the way, just because we are on Facebook and people are commenting, we have our first just comment, not a question, here at the bottom. Dr. Gulur, great.
Oh wow!
Thank you.
So congrats, Doctor. Yeah. So that's always fun when those come in. But we also have another question that says, what is the difference between a polyp and a mass in the colon?
Dr. Lim?
Yeah. Who wants to take it?
I can take it. So essentially polyps, especially if it's a precancerous polyp, it's a precursor to a mass. So think of polyp as like a growth in the in the lining of your colon that it's not likely to cause any problems, but if it's left untreated over a long period of time, or over years, can transform into something more severe, like a mass / colorectal cancer. In a more technical medical term, a mass happens when there's invasion to the deeper layer of the colon, and that's how we define a mass as compared to a polyp. And so a polyp is a precursor, or it's a small growth a growth that can eventually transform into a mass. And that's why we do colon cancer screening or a colonoscopy, is to find these polyps, take out these polyps before they can transform into something more serious, like colon cancer or a mass. But then, kind of explain the difference.
And I'd like to add, Buffy, you asked the best questions. Really, really good question.
I mean, that's a really good question. A lot of people don't know.
One of the easy ways to think about is, its size and shape. So polyps generally, they can come in various shapes and stuff, but once it crosses a certain threshold and it loses its definition and starts giving you, certain indications, whether it be bleeding, whether it be an ulcer, you start calling it a mass.
Yeah.
When you are concerned. Polyps generally have some definition, some shape, and do not have those very alarming features.
So if a patient has polyps removed, is there anything beyond that would need to be done? They go off. What happens to the polyp after it's removed?
So once a polyp is cut out, we capture it in what we call a trap, and we send it to our excellent pathologists who evaluate that at a microscopic level, and then they parse out what type of polyp it is. As Dr. Lim mentioned earlier, adenomas, that's what we're looking for, and there are different types. And they also look for features that may suggest, where the question was asked, what is pre-cancer? Something with the potential to turn to cancer, whether that potential is being realized. And it happens in a stepwise fashion. That's what's one of the unique features of colorectal cancer, and which makes it an excellent target for screening. It follows this defined process, and they're looking for what part of that process is evident in that polyp. And then they let us know. And then based on, well-defined guidelines, it helps us determine, well, how likely is it that new polyps will form? How soon should we be looking? And that's, again, what helps us determine, tailor-made screening intervals, plans for patients going forward.
And, we have another question here that just popped up from Karen asking, can a diet change prevent polyps?
Do you want to take that, Dr. Gulur, or do you want me to?
Yeah, so it's a tough one to answer. So
yeah,
studies have suggested that having more fruits and vegetables makes it less likely for you to develop colon cancer. Having more red meat, processed food, makes it more likely for you to develop colon cancer. But no study has shown that having a diet of only fruits and vegetables and avoiding all red meat or processed meats will prevent colon cancer. So in the end, yes, it's a good thing to change your diet for many reasons, not just colorectal cancer, cancers in general, cardiovascular disease. There's so many good reasons to have a healthy diet, but diet alone will not prevent the formation of polyps or the development of colon cancer, sadly.
Yeah.
Otherwise, my version of TB12.
What? Okay. Just wanted to jump in on that question as well. So besides diet, again, a lot of the smaller studies have shown that sometimes smoking and alcohol can also increases your chance of polyps. Again, those are small studies. It's not, replicated in bigger studies, but something to think about. Maybe instead of smoking, maybe try to cut down a little bit, and that can perhaps reduce your risk of getting colon cancer as well.
Thank you, Dr.
Yeah.
Thank you, Dr.
Right.
Tim, did you have more from the listeners?
As we're sitting here, another one came in.
Okay.
The question is, if someone has genetic testing done and tests positive for the PMS2 gene, do you know what their increased risk for colon cancer is? But you may want to start by explaining what is the PMS2 gene for the audience.
Oh, I'm going to let Dr. Lim handle this one, 'cause this is hard.
Oh, Dr. Gulur.
I'm
Well,
here for the easy questions. I'm the older person.
yeah. I mean, unfortunately, I think I have less experience in a PS2 gene. But in general, PS2 gene, you have some risk for colorectal cancer, and you have a higher risk for an endometrial cancer. So I would have to look up the specific guidelines for PS2 gene mutation. But in general, anyone with a family history of colon cancer, especially if it's a heavy family history, should always get some sort of genetic testing, because there's so many different types of genetic inheritable colon cancer disease, things like Lynch syndrome or FAPs, stuff like that. And when you are tested positive for that gene, if it's PFS2 or MLH or one of those genes, there is very specific screening guidelines for those subset of patients. And we're talking screening colonoscopy as early as age 25 for patients with certain genetic condition. I don't remember the top of my head the specific guidelines because there's so many of them. But in general, if you're tested positive for any of the genetic, the genes that predisposes you to colon cancer, especially if you have family history of colon cancer, usually the colonoscopy guidelines are much more stringent. You'll be getting colonoscopy every 1 or 2 years at age 25, for certain genetic disease.
So,
Specifically PMS2, yeah, I'm not sure.
Yeah.
Maybe Dr.
So,
Gulur have read something.
basically, no. Basically, what the individual is talking about is, something we call hereditary non-polyposis cancer syndromes. They're not essentially the gene that causes a loss of expression of these genes. They're tumor suppressors. So when you lose expression of these genes, then you are more likely to develop colon cancer, or many extraintestinal cancers, whether it's the endometrial cancer, bile duct cancers, the stomach cancers. There are numerous cancers that you could be predisposed to. And as you know, genetics is a study that has exploded in the last 20 years with the sequencing of the human genome, that they're able to now differentiate, which previously they were not, which type of cancer you're more likely to have, and then tailor make a surveillance strategy for you. Before, it was just lumped into Lynch syndrome, HNPCC, and we would screen everybody with colonoscopies, urine cytologies, having endometrial sampling done, or pelvic ultrasounds. It became it was much more broad-based, and a lot of people went through tests that they may not need to. But now, with the help of genetic counselors, frankly, we can develop these tailor-made plans for individuals with these familial colon cancer syndromes. I hope that makes sense.
Yeah.
Okay.
Great. Thank
Wow.
you. Amy, back to you.
Yeah, that is a lot of information, a lot to digest. So thank you. Stool-based tests. Is that a take-home, or do I go to my primary care to have a stool-based test if they determine that may be a good first step?
They're actually, they can be mailed to your home, or you could pick up a kit at your primary care providers if you happen to be there and would like to. And they're done at the convenience of your home. You have to follow certain instructions, so to avoid those false positive tests that we were talking about earlier. So yeah, it's not ideal for you to have these tests done at your primary care office, because you may not have had time to make those dietary changes or avoid certain medications that may interfere with an accurate result.
Thank you. And Dr. Lim, so we said at the beginning of the program we were going to dispel some myths. So I hear a popular question is, colonoscopy is just terrible. Help me dispel that is not necessarily the case, and tell us about colonoscopy. What is the colonoscopy?
So in general, I think people find colonoscopy unpleasant because of the prep that they have to take the day before and the morning of. So that usually, when people come for colonoscopy, I often tell them, your battle is done. Now you get to sleep, you get to get some little sedation to go to sleep, and we will do all the work today. So the procedure itself isn't painful. For the most part, you'll be sedated during the procedure. I tend to say there's about less than 1% risk of infection, tear, or perforation causing a hole in your colon. And so the process of colonoscopy involves putting a scope from the bottom, and it goes all the way to the first part of the colon to screen for colon cancer, colorectal cancer. So we go all the way to the first part of the colon. If we see any polyps, we'll then remove it during the colonoscopy itself. The procedure itself, it does not take long at all. It takes about anywhere from 20 minutes to an hour, depending on how challenging or difficult the colonoscopy is. In terms of the preparation of the colonoscopy before the day, that is, in a lot of people's experience, maybe the most unpleasant part of the experience, because they have to take the preparation the night before, essentially have induced diarrhea the whole night, and then usually depending on institution, usually take the prep again in the morning, 5 hours before the procedure. So the colonoscopy itself is not unpleasant. It is the preparation before that people often find a little distressing, because it's not comfortable. They get a lot of diarrhea, and the preparation itself a lot of times are not extremely pleasant to drink. And just to talk a little bit about the preparation itself, there are many different types of preparation as well. There are the small volume type of preparation, the big volume type of preparation. We usually split them because in studies, it has shown to be it's just more efficacious. The cleaning process is easier, it's more pleasant for the patient. And there are different volumes that, when you see your gastroenterologist, they can sort of tell you about the different types of preparation. And so depending on your, comorbidities, depending on whether or not you have other medical problems that would preclude you from getting some of the type of preparation that we usually do, that will decide what kind of preparation you will get, and so forth. So in general, I don't think colonoscopies are scary. I think it's the preparation itself it could be unpleasant, but there are ways to make it more palatable or a little bit more pleasant. And I can kind of talk a little bit if we have a little bit of time. Essentially when patients call me and say, like, I'm vomiting, I'm nauseous, I can't tolerate this, I tend to tell them to just not chug it. Like, people tend to have a kind of conception that you have to chug the whole thing so that it works. I tend to tell them, take a straw, you can chill it, put it in the fridge, ice it so that it's a little bit more pleasant, and you can sip it. You don't have to chug it. And sometimes it's a little more pleasant if you put some ginger ale or some clear liquid with it so that it tastes a little bit better. But obviously, we do not recommend colored drinks or anything that would kind of color your bowel and cause like a false positive results in your colon. So those are the general ways that I tend to advise my patients to do. And oftentimes, once they try all this method of chilling it in the fridge, mixing it with ginger ale or sipping it with the straw, they tend not to call me in the middle of the night after that. So problem solved, and next day I see them and they're fine with the prep. So it is not as bad as you think, is what I'm just trying to say. And there are ways to make it more pleasant, which those ways that I've mentioned.
So the day before prep, it starts at a certain time, and the prep being a drink, it's not a food that you eat. You're eating a sort of a special diet, drinking the prep.
Yes. Correct.
Interval throughout the time and up until your appointment time, correct?
That is correct. So the day before, generally we put our patients on a clear liquid diet just to help clean out the bowel as much as we can. And if you're baseline constipated, even the day before, so 2 days before, we put them on a sort of like a full liquid diet just to help cleanse them a little bit more. So there's a lot of all this information will be given to patients before the colonoscopy. They get pamphlets and leaflets of instructions on how to prepare for the colonoscopy. So it's not it's a very clear process. Like you will be told exactly what to do and how to drink it and everything. So
great, thank you. Dr.
Great.
Gulur.
And,
Yeah, no, I think it came out like the prep is a process. The procedure is scary because it's mostly fear of the unknown. But after someone's been through a colonoscopy in this day and age with the availability of anesthesia services, it's actually a great experience. Many patients wake up quite happy, quite pleased with the myth dispelled. It is painless to them. They wake up with the best sleep they've ever had. but there is no way to avoid the process that comes beforehand,
Yeah.
which is, to provide a high quality colonoscopy. It's not just doing yet another test. It's doing the right test the right way to have the right result. And unfortunately, that involves a little bit of work. And thankfully, that work is over, 3-year, 5-year, or 10-year interval. So it's not something that you should work yourself up about. It's like many things. It's the work you put in is the result you get out, and it's an important result, very important.
Thank you. Tim?
Great.
did
And
you have-
Amy, we have another question on Facebook. So Jennifer Nelson wants to know, what percentage of the population is compliant with colorectal cancer screening, and do you know what percentage of this cancer could be prevented with proper screening?
Ooh.
I think Dr. Gulur, that's all you.
So my data might be a little dated, but at one point, and I think you might have the more recent information with the American Cancer Society, but it used to be only 51% of the population had any sort of screening, and that's a few years old now. So it may have changed with the excellent input of the primary care doctors that have made it their mission to get people some sort of colorectal cancer screening. As terms of what percentage of colon cancers
Yeah.
could be prevented, it's a very hard one to answer. Even what we measure is how many fewer cancers are being detected since colon cancer screening has become generally available. Unfortunately, that can be skewed by other factors. Colorectal cancer rates and death from colorectal cancer was decreasing year on year for over a decade, but then over the last couple of years, that has somehow reverted back to a slight increase. Am I mistaken?
I'm just doing a little bit of research right now as you're talking. So it seems like in the year of 1975 to 2016, it's been going down. But yes, you are absolutely correct in that it's been up trending slightly ever since then.
And I will
Yep.
just say the pandemic has created.
Definitely. Yeah, that's one
Yeah.
of the major setback. Yeah.
Yeah, so we encourage patients who have missed their screening or who have come due for screening and have not yet been screened to please call your primary care, or if you know you're good to go and you're ready to schedule an appointment at St. Joseph's Hospital, please call the number down below that Tim has put for you, because on-time screening saves lives. It's incredibly important. Let's see. Oh, another myth. If I have a colonoscopy, I have to miss the day before work and I have to miss the day after work out of the colonoscopy. Is that true? How much time should I plan on leaving work for to have a colonoscopy?
So in general, I don't, because the preparation process starts usually in the evening time. So usually people still go to work the day before. We tend to say that during the day of the procedure is when it most likely a lot of people will take that day off, because if your colonoscopy is not till 1 or 2 p.m. in the morning, you'll be taking the preparation and you'll be going to the bathroom all day. So it's just more of a logistic problem that you just can't go to the bathroom while you're working all the time. Generally, after the procedure, we tend to, tell them that they have to find some sort of transportation to go home because they're just not in the right state of mind or right conscious mind to drive home or do any high functioning activities, especially since they have gotten sedation for the procedure. But the next day after the procedure, people can resume activities, at baseline. They can do what all the regular things that they usually do. So it's really the day of the procedure that people tend to take a day off, just because of the process of prepping and getting sedation and the colonoscopy itself.
Thank you.
Yeah.
Any more questions, Tim, out there?
Not yet. We're keeping an eye out.
Okay. I have one as to, can we revisit just a few of the most concerning symptoms, just to point those out? Are there a top couple of symptoms that are concerned that if someone was asking you about, you would say, yes, we should definitely look further?
Yeah, so I can answer this as well. So essentially, anybody, especially as in an older age group, anybody with a change in bowel habits, and I'm talking, either constipation or diarrhea, who hasn't had a recent colonoscopy with the change in bowel habits, should probably get a colonoscopy for further evaluation. Anything like blood in your stool, if you're noticing dark stool or bright red blood in your stool, any abdominal pain that is very severe, or just decreased PO intake, weight loss, those are concerning symptoms that that I would be concerned about, and I would probably do a colonoscopy if you have not had one in the last year or so. And just in general, if you're feeling like your GI symptoms, if you're feeling that you have some GI symptoms that are a little bit abnormal than the usual, and that there's a change, you should probably see a gastroenterologist for that, because again, colon cancer can present asymptomatically, which means you may not have symptoms until the very late stage, or there's a lot of patients present with very vague symptoms like, oh, I have some pain here and there, I've lost about 10 pounds, but I'm still eating, or my weight has decreased and I'm not eating as well. So those are very concerning symptoms. And blood in your stool, that's a no-brainer. You should definitely come and see us, and we'll probably offer a colonoscopy. Yeah.
Well, those are the
Gulur,
questions.
if you have anything.
Oh no, it's kind of, we have to balance giving these symptoms out, and then also just alarming people. It's persistence of symptoms. It's the unexplained symptoms, like abdominal bloating, abdominal pain, constipation, diarrhea, rectal bleeding. Sometimes it can be vague symptoms, fatigue, and you're found to be anemic by your primary care provider. These are various reasons why people are referred to us to be evaluated for colon cancer. And I was able to find some information for that question, about, so we're not able, there are no studies published that tell us how many cancers themselves are prevented. But they do estimate by having, if 100% of the population is screened, they can reduce 68% of colon cancer death. So that's the way they judge how successful we would be with screening strategies. It's not easy for them to say, you can reduce 100 colon cancers or 500 colon. It's colon cancer death that is the measure.
Great. I have another question, Amy, as well, that came in. If you said that if you're 45, that's the new recommended age for a colonoscopy. But if you're under 45, is that something that insurance will cover? Or do you have to be 45 or over for insurance to even consider it, assuming there's no history of colon cancer in the family? And do you know?
So Dr. Lima, do you want to answer that, or
No, you can go ahead. Yeah,
so,
I think you have more experience in that aspect.
So the reason these age limits are imposed is they try to balance a cost to benefit, risk to benefit, and which population would benefit from having screening. We can perform screening on any age group, but the number of people that need to be screened to find one colon cancer would be so large that most people undergoing that screening test would be exposed to some risk without any clear benefit. And of course, cost becomes a factor. So that's why they determine these ages, that even now it is believed that people over the age of 50 are the ones that have the best risk to benefit or cost to benefit of having screening for colon cancer. Between 45 and 50, it's not as robust, the data, but it's data enough for insurance companies, cancer societies to agree that it is still within a favorable ratio for them to pay for having colon cancer screening. So remember, as Dr. Lim was mentioned, there are risks from sedation, there are risks from the procedure, and we have to always keep these in mind, that we are putting people at risk, but to their benefit. Back when I was training, I had a very smart professor who once said, "You're 10 times more likely to get colon cancer than to have a problem with your colonoscopy," which was how he would convince people to go through to screening. But remember that those numbers come from the age groups that are determined to be at highest risk. So if you're 20, and you have no family history, and you're going about, it's much more likely that you don't have colon cancer and that you will have an unnecessary test with some finite risk, versus somebody who's 50.
Great, thank you.
Tim, any additional questions?
No more questions here.
Okay.
Everyone must have left the live discussion at this point.
Yeah. But I will just say, because Amy, do you have more questions on your list?
No, we have gotten through all of them.
So I would just say, maybe just a reminder to our audience about if you are over the age of 45, or if you have some concerns about, maybe a family history or whatever with colon cancer, what would be the first step somebody watching this should take? Call their PCP, call the gastroenterology office at St. Joe's. What's the first step?
Call your PCP. So in St. Joe's, what they can do is they can, sometimes they, for example, they show up for a colonoscopy even when I've never seen them in clinic. So that's a very common thing that I see a lot in St. Joe's. So what they can do is, if it's just a screening, a clear-cut screening colonoscopy, they'll just put in a referral. They'll show up for the colonoscopy of all the instructions, with the preparation and everything. But however, if they have any specific questions at all about, their specific GI issues that they want to talk to the gastroenterologist about before getting a colonoscopy, then, very happy to see them, and they can make an appointment with the St. Joe's Hospital gastroenterology group, which is that number over there. Yeah,
I'd like to get that message across, that if you're having symptoms, if you're having fears, in the back of your mind, don't hesitate to bring them up. Sometimes people are reluctant to discuss their GI symptoms because of whether it's cultural, whether it's societal. They don't want to discuss these symptoms, and for any number of reasons. They shouldn't be afraid to do so. If they have access to their primary care, they can. If they feel that they want to meet with a specialist, well, you have the number right there. We're happy to talk to you, happy to meet you. But what we want to do is make you comfortable. That's it. Make you comfortable discussing your symptoms, or getting screened by any means that you feel that you are comfortable with.
Yeah, so
Great.
essentially, just to echo what Dr. Gulur said, bottom line is just get help if you have any issues or any questions about whether or not it's with your primary care provider, whether or not it's with a gastroenterologist. Just reach out to someone that has has knowledge in this field, because we're always available to help, and we're just always available. And the primary care provider are very excellent physicians as well, and they are very equipped with the knowledge of the latest guidelines for colonoscopy screenings, and they will be able to help with the GI issues as well if you wish to talk to them first. And we're always here. The appointments, you can make an appointment to see any of us at any time if you have any questions at all. Just don't hesitate to reach out. Exactly, the number's right there.
And I just want to say I have the awesome opportunity of being the liaison between the ACS and the St. Joseph's Hospital. And I am also a cancer survivor. And I was diagnosed with breast cancer, and I know it's not colorectal, but I was diagnosed at 32. So I was well younger than the recommended cancer screening, but I felt like something was wrong. And if any of you are sitting out there tonight thinking, oh, I just don't want to deal with it, please deal with it. Please deal with it. I would not be here sitting with you this evening if I had not called my primary care. and then they had taken the appropriate actions to ensure that I got my screening. So please, if you have any concerns, make that phone call. You are in safe hands. And we know COVID has really put cancer screening well behind the 8 ball, and we will find cancers at a much later stage. And we don't want that. Please get your screening.
Thank you, Amy.
That's very well said. Yeah.
And Dr. Lim, you guys shout out here. Thanks for the clear instructions. So congratulations. you both got Facebook shout out.
Thank you.
All right.
Thank you.
One
Call this number.
Yeah.
So I think that's what we have for tonight, right? I think that's the end of our show. We want to certainly thank again these two incredible providers for joining us, for sharing all their information. Oh, look at this. Brooke says you all rock, and we completely agree. You guys rock. We love hearing this information. We think it's so important for our patients and for the community in general. And Amy, thank you again for joining us from the American Cancer Society and leading the conversation and asking all the questions. And we try to do these Facebook Live sessions as often as we can. So of course, if there's things that our audience members want to hear about in the future, we'd love to hear about them. So if you want, if there's other topics, we will try to get the providers that can come on and share their knowledge. And oh, look at this. Karen says there are awesome blueberry muffins waiting for you after your procedure.
They are so good.
So there you go. Oh wait, you know what? The compliments keep coming. You're both amazing.
Oh
thank you.
Thank you.
I know.
Thank you for listening.
It gets better and better. So thank you both. Thank you, Amy. And everybody.
Amy, thank you for being an inspiration for all survivors.
Yeah.
Thank you so much. Thank you. Thanks for all you do. Keep everyone safe.
Thank you, Maribel. See you tomorrow.
I'll see you tomorrow.
All right. Thank you, everyone. Have a wonderful night.
Thank you.